Before that, on the acute care inpatient, it was awful. So it stopped. Then they moved to outpatient. It stopped. Anyway, they are spending more than, I don't remember the last figure, 18% of the GDP in healthcare. Okay? In France, we are 10. And we are expensive concerning European Union standard. Okay? But I think this is completely misleading. I think people, most of the population, think that they wish to have good healthcare, good quality of healthcare. They have concern when there is an accident or some spectacular things. I don't think that their goal is to contain cost. Is to contain cost for a certain quality. And as there are a lot of innovation, technology innovation, you see the quality is increasing. I very often say that to my students. You see, you can say what you wish, but in France, the life expectancy between the end of the Second World War, 45, and now has increased for men and women by 20 years. That means that at the end of the Second World War, after the war, of course, there were 60. Now it's 80. But when you compare, it's basic arithmetic, 20 to 60, that means that in 70 years, the life expectancy has increased from 1/3. 1/3. And the same for the men. There were, I don't say, for the men was 60 to 80, and not for the women 65 to 85. That has a cost. The cost has not been contained. I'm sorry. But so, I know I put that for I know the government are very pleased by that. Yeah, we're going to contain cost, don't worry.
Looking at what you just said, is that, like for example, you said in the US it's 18% of the GDP, in France it's 10%, and they are actually worried about controlling cost. But actually India is struggling with a different kind of problem. They have always underfunded healthcare, and only this year, in June, the government announced it's going to increase its contribution, not the overall GDP, its contribution from 1.5 to 2.5. The total is actually 4.9 something of the GDP, and therefore it's promised after so many years of pressure and interest groups work. So it's just promised that by 24 it will reach 2.5, and there's some kind of a self-congratulation about this idea that you're increasing. That's fine, but isn't it equally true that if you just increase your investment without looking at what is the output, you may be actually wasting money?
Yeah, and there are other examples where the introduction of case mix has been justified by increasing investment. For instance, in Portugal in Europe was among the first to implement the DRG system, and at that time they were just entering the European Union, and they have a very ambitious program to develop the healthcare infrastructure, and they have done it, and they have control by the case mix system. Okay, so I think it's a relation between quality and cost, and so you see the UK, for instance, during a lot of years where at the old time where they were members of the European Union, they were shown that, it's very good, they have the same, more or less the same output as other European countries, and less spending, and then Tony Blair decided to invest, and now, before leaving, before Brexiting, they just are on the mean of the European Union as spending. So I think this, but it is important for, if you discuss with any government, yes, it will going to contain cost. There is no evidence. But you see, I think can be done if you are in a very increasing period, uncontrolled, you slow down the slope a little bit. So the hospital, the first surprise, there was no bankrupt. No American hospital have been bankrupt after the introduction of the DRG. Pity, but it's like that. Huh? For they have probably due to the American system, they have reacted to the incentive and has worked. So there is no bankrupt, there is no bankrupt. And on the other hand, there was a lot of investigation and there is no obvious decrease in quality and safety. And this has been done in many other countries. There is no proof that this has decreased the quality of care. As I was showing with the fears. You see people say, oh, boo, boo, people are going to die, and so on, so on. The Norwegian people, Norway, Europe, have done very precise things showing in Norway a small readmission rate increase, okay, but without effect on the mortality. Okay, so, alors, cost control at the level of type and volume of patient. For a lot of managers, it is very good to know. You control the cost. You say, oh, at this level it's okay, at this level it's not. So we have to do something. But you don't do a generic thing. You do a very specific thing. Comparative analysis between departments for the same type of patient. As well, this will be, have been very useful. Potential to negotiate with purchaser of care. For now you have argument, you see. I have increased my case mix on very high cost DRG. That's not my fault. Huh? It's a fact. So I need more resource. Predictable revenue stream, that has been very appreciated. For by type of patient, you know more or less, and you can plan for the year after, you see. And you have a series, an historical series, you see this is going up, going down, so it's very interesting. And incitation to new relation between management and medical staff. I will come back after with a Terry slide. And service and care migration to most appropriate setting. So the only criticism against that is to say there was other factor, driving factor to do that. But in all the country where it has been introduced, really the healthcare setting where have changed. So
one of the ways of looking at DRGs and case mix is that it's a tool for efficiency, and therefore
equity.
Equity. Okay. My question.
Equity and efficiency.
Yeah. My question is actually on that. To what extent do you feel what you just said can be substantiated? Because if you're looking at, say, predictable revenue streams or cost control at the level of type and volume of patients, equity, okay, at the government payers level, I can see what can happen. But at the control level, at the hospital level, if the motive for hospitals to treat only high DRGs, so doesn't that automatically mean that they will avoid the low DRGs or low case, and that would lead to a decrease in access for those patients? How do you, at the societal level perspective, take care of that behavior?
Yeah. This this is an argument, and how to say, there is a risk, I think, at this level. And for instance, taking the example of France, I know, what is interesting is, as we have two hospital systems, one public and one private for-profit, the difference is that the public hospital has no right to refuse any treatment, okay? And on the other hand, the private for-profit clinics have the right, except in emergency, if somebody is arriving at the private for-profit clinic in emergency, they have to take care of, and then to transfer, but after they can transfer to the public hospital. And there is evidence in France that public hospitals, since the DRG system, are receiving more transfer from hospital private for-profit, okay? So, but my feeling is that's not really related to the funding by DRG. This is related to the bad French healthcare system, where it is not understandable from an international point of view. So I don't speak as a French citizen, but as an international expert. It is not understandable that the same mandatory health insurance system, okay, so everybody must pay to the insurance, and everybody is reimbursed or paid for what he needs, as such two different systems, paying, you see, public hospital and forbidding them to refuse any type of patient 24 hours a day, 365 days a year, and allow that to private for-profit hospital. That is the problem. It's not the problem of DRG. It's the problem of the system. Why they are doing that? You see, in a lot of countries, for instance, in Australia, the private for-profit are paid, or in Netherlands, they are paid by private health insurance. So it's different. They have contract, negotiate, whatever they wish. But in the case of France, is that it's paid by the national public, we say, social health insurance system, and which is in fact completely controlled by the government. You see? So I think your question you're asking is there is a risk. There is a risk to maximize the profit.
So it's more like a rule problem rather than a tool problem.
Yeah, but it's okay. I think I finished. Yeah. Yes. Sorry. Internal management. So that was funding. And now internal management. It's more fun. So the ID is presented on case mix, or DRG, creates a common language between clinician and manager. So it's the slides are coming from Terry, yeah? And both resource and that there is some difficulty, I think, but we don't have any hospital manager in the room. So.
We invited many of them.
Yeah, they didn't come. So there is some difficulty to speak between healthcare professional and manager. So even if they were here, I will say that. And so that you see the manager on the right has in mind the price and appendectomy without complication, which is the DRG name of a group, okay? And so, and the physicians speak about inflamed appendix, which need an appendicectomy. And so the question is, are they able to reconciliate on the group, on the DRG group? So I think that is an analysis of the reality in most of the country. Medical decisions are made by doctors. It's like that. Nursing decisions are made by nurses. It's like that. All other decisions are made by lay managers, finance for the income and expenditure, supply, workforce, and hotel service of hospital. And then doctors and their workshop more or less as a kind of substitute, and that's the hypothesis of Terry. The only thing which really is of interest for the physician in an hospital is to save his own time, not to stay too long in the hospital. So he give orders, bloom, bloom. That's it, and the rest. So, and so, of course, the situation is so. She is using a kind of a sociologic word by Kubler and Ross on the 5 stages of grief between manager and hospital.